Um, yes, sir.
हाँ
I can see the screen.
हाँ.
लेकिन इस पे बस participants ही हैं.
Not the other one.
नई slides तो नहीं आ रही इस वक्त नजर.
Okay, then this means that I have to stop sharing and share again. Okay, let me see. Wait. But this and other people are joining in, so you have to make sure that they are in here as well.
Yes,
Okay,
sir.
can you see my screen now?
I can see a blank screen only.
Well, technology, you see, unfortunately. Okay, so you people cannot see. Okay, let me end the show again and share it again. Come on. Really? Okay. It always, whenever I start, it always starts with something problematic. Okay. Technical stuff. Mm, okay. Yeah. Okay. Is the recording on?
Mm, yes, sir.
Okay.
Recording is on.
And now you can see my screen, right?
Sir, I can't see it. लेकिन किसी और से पूछना है. कोई और बता दे please.
Yes, sir. We can see the screen clearly, sir. It says highlights of
Yeah.
ICD-11 classification of.
जी सर नजर आ रही है
Okay. I might have
Perfect.
signal issues.
So Mahanur, you have to swap like just like me when I was struggling. So we can start, right? Okay.
Yes, sir. Yes, we can.
Bismillahirrahmanirrahim. Thank you very much, all of you, for coming in. And I hope that you went through the previous presentations. If not, then I will just recap a few of the things which I taught earlier. We were talking about ICD-11 and the diagnostic criteria. The most important part of this presentation was that we have to use the coding system, and the coding system is made in a way that mental and behavioral and neurodevelopmental disorders are labeled from 6A00 to 6E8Z. And again, the important thing was that we have to use morbidity and mortality statistics. This is on WHO website, and all you have to do is to again see the patient, make the some diagnostic thing in your mind, click the things on the website to reach to a diagnostic code, and it will be much easier. So there is nothing like we have to either uh, memorize it or learn it, or maybe we have to go for other details about it. So you should have a cell phone. You should have a ICD-11 link on WHO website, and it will be much easier. Then we talked about some changes that are suggested in ICD-11 in various disorders. Most important of them, the sexual disorders and identity disorders have been clustered in a separate heading. Then the OCD, previously called OCD and OCPD, is now grouped as obsessive compulsive recurrent disorders, OCRDs. And OCRDs include multiple other options as well. So it's a broader category now. And OCRDs include certain other disorders, which we talked about it in last time. We also talked about certain other disorders like body integrity, dysphoria, gaming disorders, compulsive sexual behaviors, intermittent explosive disorders, and today I will be starting with premenstrual dysphoric disorder. So it won't be a very long presentation, but I will try to be as brief as possible. In between, if you want to stop me, ask me any questions, please do so. Don't hesitate. Some of the questions asked last time, so I offered that if somebody wants any question related to ICD-11, they can just text me in the group and I can respond to it or prepare it, but I never received any question. So I don't know whether it's a good thing or a bad thing, but we will see. In March 2023, there is a WPA thematic congress in Karachi. I definitely would like all of you to participate in it. And we will be presenting the real lifetime data related to the usage of ICD-11 there. And I hope we'll be able to see you all there as well. So premenstrual dysphoric disorder, GA 34.4. The ICD-11 premenstrual dysphoric disorder, PMDD, previously it was called PMS, premenstrual syndrome. Now it is PMDD, is differentiated from more commonly occurring entity, premenstrual tension syndrome, by the severity. The inclusion of PMDD in the research appendices of the DSM-3R and DSM-4 stimulated a great deal of research that established its validity and reliability. Premenstrual dysphoric disorders is a cross-listed in a subgrouping of depressive disorders due to prominence of affective symptoms, although the primary location is in the ICD-11 chapter on diseases of the genitourinary system. So the reason why this code is not mental, GA 34.4, is because actually this diagnostic classification for PMDD is now including in genitourinary system. So no more mental only, it's more now physical as well. So that's the reason why the classification was shifted from mental and behavioral disorders to general systemic disorders of the genitourinary system involving mental ailments as well. Neurodevelopmental disorders come first in ICD-11. According to the lifespan approach followed in entirely, disorders of acquisition and execution of specific intellectual, language, motor, and social functions have been included here. So all the disorders that can be there from mother's womb to the birth to the early life years, they all come here. And this provides a comprehensive set of behavioral indicators, 36 tables for ID and adaptive functioning domains, conceptual, social, practical, all things are considered here from childhood, adolescence to adulthood, and 4 levels of severity: mild, moderate, severe, and profound. Those terms were actually, they disappeared for a short period of time from the classification. They are back now again as well. In autism spectrum disorder, both childhood autism and Asperger's syndrome were incorporated. Qualifiers to embrace the extent of impairment were added as well. ADHD has been added in this group and replaced by the term of hyperkinetic disorders. This was an effort to indicate common co-occurrence of other neurodevelopmental disorders, developmental onset, as well as to lessen the stigma by differentiating it from dissocial or disruptive disorders. And again, the qualifiers are added into it to make it more comprehensive. Chronic tic disorder or the Tourette syndrome were actually classified in the chapter on diseases of the nervous system, but are cross-listed here in this group as well. So this tic disorder, because it comes with some neurological abnormalities as well, so it is present in both the situation. Ideally, tic disorder is now a nervous disorder, but we psychiatrists are definitely treating it. And but it comes under the heading here as well. So overall, wherever there is a gross pathology where the brain and the nervous system is involved as far as the structure is concerned, those kind of disorders are usually mentioned at both places. So this is another a good thing about it. So the childhood disorders are much more broadened. They are associated with the diagnosis of the children, diagnosis of the physical health of the children, diagnosis of the mental health of the children, diagnosis of the neurological problems with the children, and all codings are easier. So this never means that if you see a person having only tics with anxiety, you cannot assess it. You can still label it. The only problem you will face would be probably it won't come under the section 6. It will come at other places as well. So the coding probably will be different. And again, don't get yourself confused. Go to MMS, put the diagnosis, and you will see all the details about the diagnosis. Schizophrenia and other primary psychotic disorders, most important and the bread and butter of psychiatry. The term primary has been incorporated here to exclude the cases of affective or induced psychosis. So substance-induced psychosis, schizoaffective disorder, affective disorder with psychotic symptoms, those things are actually now labeled as primary. Other than that, are labeled as primary. And if it is with something else, it is usually called secondary. Pointing that psychosis being the core feature. Other changes were in attendance with the DSM-5, like de-emphasization of Schneiderian first-rank symptoms and elimination of subtypes of schizophrenia due to their lack of predictive validity or utility in the treatment selection. So previously, we were more focused about the types of this schizophrenia that, okay, this is hebephrenic schizophrenia, this is simple schizophrenia, this is other various other forms of schizophrenia. Now, you don't have to worry about the subtypes because the schizophrenia in whatever form, it will be treated the same unless or until schizophrenia is associated with catatonia. And as I mentioned to you earlier, the catatonia has a separate heading. So then catatonia, schizophrenia, and anything associated with it will be treated simultaneously rather than treating one thing at a time and going sideways. Uh, Dimensions have been described, including detailed description, the positive symptoms, the negative symptoms, the depressive symptoms, the manic or mood symptoms, the psychomotor symptoms, and cognitive symptoms, which was initially in the beginning of the classification system were not considered. So the various domains are adding up in schizophrenia diagnosis. The polymorphic picture of the acute and transient psychotic disorder has been particularly emphasized for the diagnosis. Otherwise, no major conceptualization changes were done in schizoaffective disorder or a schizotypal disorder. So again, some of the things which were there and probably used very frequently by the psychiatrists, like schizoaffective disorders, they haven't changed it. Although there was some discussion in the beginning that this term should be removed because we have schizophrenia, we have bipolar disorders. You can label 6A20 with 6A, whatever the bipolar disorder diagnosis is, and then treat them accordingly. But then there was some confusion generated, and ultimately there was a consensus that for the time being, these terms should be left like this, and maybe in times to come, they will be further changed. So the mood disorders come under the heading of 6A80. And while diagnosing a mood episode, a longitudinal pattern was given importance in ICD-11. Though symptom count was de-emphasized, depressive disorder is one of the few places where it was used. So previously we were asking multiple situations that this episode initiated from this time period to this time period, blah, blah, blah. Now, ICD-11 actually longitudinally see the mood disorders. So even if somebody had the first episode at the age of 26 and the second episode at the age of 42 or 47, it will be considered as an episode. That's the major difference. And again, still, some of the things are not very clear to me as well, but I will definitely feel that this is a better option. So you call the person, previously there was definite thing that these episodes should be in this much specific period of time if you really want to label it as a bipolar. Now there is no time bar as well. Persistent mood disorders in ICD-10 consisting of dysthymia and cyclothymia has been eliminated and including in depressive disorders and bipolar disorders. So these terms were again very confusing. So dysthymia, cyclothymia, rapid cyclers, they are all various kind of situations, but ICD-11 believes that there are only two types of bipolar disorders, bipolar 1 and bipolar 2. If there somebody is having dysthymia or cyclothymia or rapid cycling, they should come in bipolar disorders or mood disorders, and one or two types should be there, rather than making it too complex and confusing for further management strategies. Presence of typical contrapolar mixed symptoms confirms the bipolar 1 diagnosis. Several qualifiers are added, like mood episodes in partial or full remission, severity of an episode, and qualifiers of melancholic features, prominent anxiety symptoms, presence of panic attacks, seasonal pattern, and rapid cycling. So all of these qualifiers have a different codes which are there in MMS. So if you have diagnosed somebody as major depressive disorder or bipolar disorder, then you have to mention about the sub-qualifiers. And again, you don't have to memorize them. I don't do that. I just use the MMS and go for it. Mixed depressive and anxiety disorders were shifted to depressive disorders in ICD-11 due to prominence of mood symptoms. So previously, people were again confused whether if a person is having anxiety disorders or depressive disorders, what should come first. So the hierarchy, mood disorders are given the priority and to be treated. With anxiety symptoms, yes. So they are again under the mood disorders. Anxiety and fear-related disorders, B6B0Z, disorders primarily presenting with anxiety or fear were regrouped here. Separation anxiety and selective mutism were shifted here according to the lifespan approach. ICD-10 hierarchical exclusion rules have been eliminated as this interfere with the specific clinical attention. So most of these disorders, they have been grouped in a way that your treatment strategies should be appropriate. If you make a diagnosis properly, the treatment strategy is very clear. If you won't be able to make the diagnosis clearly, of course, you will be giving 6 medicines in your prescription pad, which nobody likes. In agoraphobia, conceptual broadening is done to discard the narrower concept of fear of open spaces and related situations, such as crowds. Rather than ICD-11 gives more stress on specific negative outcomes that would be incapacitating or embarrassing in the situation. So panic disorder is kept the same, but the separation anxiety disorders over the lifespan is considered more. OCRDs, as I mentioned earlier as well, and once again, I'll be coming to it because this is important, this is different. OCRD 6B20. Despite phenomenological overlap, the OCRD group was introduced by differentiating from other anxiety disorders on the basis of presence of core feature of unwanted thoughts and related repetitive behaviors, along with the evidence of the shared validators among included is disorders from imaging, genetic and neurochemical studies. So all of these disorders, which are originating from one common theme in the brain, the orbitofrontal cortex, they are put together as OCRDs. And all of these disorders have definite genetic background. So they are grouped together as one. It includes body dysmorphic disorders, olfactory reference disorders, hypochondriasis, and hoarding disorders. Now, most of the time, these disorders were given a different uh, set of diagnoses. So, like hypochondriasis was considered to be a neurotic disorder, which was this term is used for a long period of time. Now, after seeing it, the genetic basis, the neurochemical changes, and imaging techniques, it was seen that actually hypochondriasis originates from the same area of the brain from where the other obsessive compulsive disorders are originating. So they are grouped here. So the reason why they are grouped together is because of the similarities in their neurochemical abnormalities. The subgroup of body-focused repetitive behaviors disorders, including trichotillomania, excoriation, was introduced as both share the core feature of repetitive behaviors without cognitive aspects of other OCRDs. So this is important. And Tourette syndrome is cross-listed. So it is a frequent co-occurrence with OCD and of course, because of some neurological problems as well. So the Tourette syndrome is present in somewhere else, but it is quoted inside OCRDs as well. And depressive disorders are not prohibited anymore to be diagnosed with OCD in view of high co-occurrence. So previously we were always saying that this is a person suffering from OCD with depressive symptoms. Now you don't have to say it. You say OCRD or OCD. You don't have to mention depressive symptoms otherwise as well. This is the change. Disorders specifically associated with the stress I mentioned earlier, uh, they are actually combined here. Reactive disinhibited attachment disorders of childhood are reclassified. Addition of PTSD, complex PTSD have been added. Prolonged grief disorders, which are again, I explained it to you earlier, have been added. Adjustment disorder is defined on the basis of core feature of preoccupation rather than only the response with the life stresses or its consequences, which indicates a conceptual change in ICD-11. And when you'll be reading about all these disorders in detail, you'll be more clear about it. Dissociative disorders, the famous hysteria 6B61, 6B61. The term conversion in ICD-10 is eliminated. So we don't use anymore conversion disorder. It is always dissociative disorder. And there was a huge confusion. People were asking me about it. What is the difference between the conversion disorder and the dissociative disorder? And how do we differentiate them? Because they have so much of the overlap, blah, blah, blah. So that was a confusion in my mind as a clinician and academician as well. There was very slight differences between the two. Now they have just removed it. So there is only one thing. It's dissociative disorder, and it is classification. Dissociative neurological symptom disorder is presented as a single disorder with 12 subtypes, which is conceptually consistent with ICD-10 dissociative disorder of movement and sensation. So you call it dissociative disorder, and there are about 12 subtypes in it, and you can fit in your patient in any one of them. Fugue is not counted as a separate disorder now. Identity disorder corresponds to the concept of multiple personality disorder. Partial dissociative identity disorders cover several cases of classification as unspecified in ICD-10, so that is mixed as well. And derealization disorder is moved to dissociative disorder in ICD-11. So all the people who are having conversion and symptoms related to the sensory modality, motor modality, taste, fugue, seizures, identity, personality, they all come under one heading of dissociative disorders 6B61, and there are qualifiers for it, 12 of them. You can mention any one of them if you would like to. If you don't want to, even labeling them as dissociative disorder 6B61 and some description related to it would be sufficient. Feeding and eating disorders, again, an important thing. So previously we were seeing that there is a binge eating disorder, bulimia nervosa, then there was anorexia nervosa, blah, blah. Now, they have tried to simplify it under the heading of ARFID. I mentioned it earlier as well, ARFID, ARFID. So any kind of eating disorder or feeding disorder, anything related to the subject of mental health associated with feeding and eating comes under it. Like anorexia nervosa, previously, long time back, when I started my training, it was said that the BMI should be less than 17 kilograms per meter square. It has shifted now to 18. So it's not as less as it was considered. Even people with 18 BMI are considered to be as having anorexia nervosa. And if you can broaden it, you will see that lots of celebrities come under the heading of bulimia. Lots of them. Previously, they were not considered as anorexic. Previously, they were not coming as anorexic. Same goes for the bulimia. It can be diagnosed regardless of the current weight until the BMI is not very low. And even if there is only subjective binges, in the absence of objective binges, you can diagnose it. So binge eating was a very stringent criteria. And we were thinking that people who are having the, again, urge to eat a lot, unless or until their BMI and other parameters are completed, they were not put into bulimia nervosa. Now you can put them. So anybody who eats a lot, I don't know if this is here or not. So any of the this friend who is fond of eating halim 3 times a day can be put into bulimia nervosa as well. So just on the side track. I hope you are able to hear me. Can you?
Yes,
Anybody?
sir, we can.
Yes,
Yes,
sir.
sir.
Okay. Should I continue or you want me to stop?
No, no, sir,
No,
continue.
sir, continue.
Continue.
Please continue.
Disorders due to substance use and addictive behavior. Now, previously, this was again a very challenging for me as well. So we were labeling that this person is having addiction and disorders. So now addiction comes elsewhere, and all the psychiatric morbidities related to the substance abuse comes here. Disorders due to substance use and addictive behavior. So any addictive behavior. If I'm if I fulfill the criteria for having addiction of the cell phone, now disorders evolving secondary to it will come under here. So the major conceptual change entertained in the substance use disorder is the addition of a single episode of harmful substance use. वो मैंने जी जब मैं 16 साल का था तो चर्च का एक सूटा लगाया था. Now, if you consider that episode to be a life changer in person's life, you will label it here across the lifespan as ICD-11 is going for it. So that is important. Whereas the diagnosis of harmful pattern of substance use and substance dependence suggests the need for intensive intervention. So that one binge of having a drug, it definitely created some havoc in his life and gave rise to certain kind of problems which lasted for years. You can incorporate that as well. And if person's current situation indicates that he is abusing drugs too much and that needs to be addressed, he comes here as well. So both the whole range is incorporated into this. Importantly, the so-called behavioral addictions, naming gambling disorders, pathological gambling, gaming disorders, all are introduced here. The other day, I was listening to one of the psychologists who was giving an interview in a TV channel, and they were asking about one of the game where people were trying to be homicidal and killing people around. So what was that? How it was said? I don't agree with the descriptions given by most of the people because probably I don't know. They don't read the scientific literature related to it. We have to see so many other aspects before we label that this game is having addictive. So the social and occupational decline, the day-to-day life patterns, the behaviors in general, the interactions and other aspects, they all should be considered. Blaming any specific thing, one thing, is not the solution. Seeing it as a whole is important. As far as we psychiatrists are concerned, and this is the good thing about ICD-11, it is actually giving you a broader picture and you can see where to put in who can go where. That's the good part of it. Impulse control disorders. The group includes kleptomania and pyromania. Significant changes are introduction of intermittent explosive disorder, compulsive sexual behavior disorder, which reclassifies ICD-10, excessive sexual behavior. So this term excessive, there was a bar there. How much is normal and how much is excessive? So they have changed it to, again, reclassified it, compulsive sexual behavior. So if somebody is watching pornography for more than 1 hour in 24 hours time period or something like that, there are specific specifiers into it. Please go read it. Don't quote me here because I'm just trying to explain it. And if the social occupational decline is there, if the other criteria are fulfilled, then this is impulse control disorder. 6C7Z. Disruptive behavior and dissocial disorders, oppositional defiance disorder, conduct disorders of childhood. These things are again put together in disruptive behavior and dissocial disorders. So if the child comes to me and he's not able to, the complaints are that he is disobedient, he is hyper, he is disrespectful, and there are so many other parameters as well. I would put him here rather than anywhere else. Personality disorders. Now, this is a big change from the past. In ICD-11, one, personality disorders have been classified as mild, moderate, and severe based on the pervasiveness of disturbances in the functioning of self, interpersonal dysfunction, severity, chronicity of emotional, cognitive, and behavioral manifestation, and the extent of psychosocial impairment. Previously, long time back, when I started practicing psychiatry, the personality disorders were not considered as main psychiatric morbidity. Then when I started off, my mentor, Professor Malik Mubashir Saab, started saying that personality disorder are abnormal phenomena which needs to be considered as part of the disease process because they can disrupt their person's life and other people's life as well. And then they started coming into the play, and then DSM acknowledged it as an abnormal thing, and then there were multiple kinds of personalities mentioned. ICD-11 has simplified them. 6D10 and 6A22 personality disorders. First thing ICD did was one, basic definition: pervasiveness of disturbance in the functioning of self, interpersonal dysfunction, severity and chronicity of emotional problems, cognitive and behavioral manifestations. So these are the 5 things. And they also gave only the 5 personality trait types, dominant trait types, which included So 5 types, personality disorders I'm talking about. Negative affectivity, detachment, dissociality, disinhibition, and anencephalia. Only 5 types of personality disorders. One type, understandable, that it should fulfill the definition. Second, it should be in 5 of these types. So all those personality disorders that we were reading in the past, they have been taken away in one way or the other, not directly, but indirectly. So now the problematic personality disorders are negative affectivity, detachment, dissociality, disinhibition, and anencephalia. A new category naming personality difficulty actually refers to those individuals whose deviant traits are present not up to the severity amounting to be labeled as disorder. Personality difficulty and personality disorders. Personality difficulty, milder traits, personality disorders, severe traits having dysfunction, severity, chronicity, cognitive and behavioral manifestations, and then only 5 types: negative affectivity, detachment, dissociality, disinhibition, and anencephalia. So maybe in the exam situation, if you'll be there and an examiner will ask you what kind of a personality disorder the person is having, if you say that this person is having personality disorder, there are only 5 subtypes: 6D10 and 6A22. Remember this, we can talk about it more. Paraphilic disorder, 6D3Z. More focus was put on the fact that the behaviors were acted on non-consenting others. Paraphilic disorders, again, this is a controversial situation. If there is consent, there is no paraphilia. If there is no consent, there is paraphilia. Now, this is very confusing for me, honestly speaking, but I will still mention it, what is mentioned in ICD-11. My personal views are not here. I'm not quoting them. Private behaviors such as sadomasochism, fetishism, fetistic transvestism have been eliminated as those found to be non-relevant to public health. However, disorders like asphyxophilia, although being a solitary, uh, so having sexual gratification by asphyxiation is still there, but the rest of the things have been removed. Paraphilic disorders. Now, this was confusing for me, and I believe that we should read about them in detail before we talk more about them. Fictitious disorder. So previously, fictitious and malingering were actually mentioned as part of the diagnostic processes. This person is malingering, this person is having fictitious disorder. The new grouping of fictitious disorders include fictitious disorder imposed on self and fictitious disorders imposed on another. It's again very fluid kind of a situation. So I still have to understand most of it. I'm still in the process of acknowledging it. Malingering is not classified as a mental or behavior or a neurodevelopmental disorder, but appears in the chapter on factors influencing health status or contact with health services. So now malingering is not actually a psychiatric disorder. It is actually a disorder of a social consequences of health and utilization of health. Strange, but it's there, but it's not as a psychiatric morbidity. And fictitious disorder is changed to either if it is myself or I am responsible for others. Very confusing, but we can talk about it. Neurocognitive disorder, 6E0Y. The group includes delirium, mild neurocognitive disorders, amnestic disorders, and dementia. The syndromal characteristics of dementia are classified in chapter on mental and behavioral and neurodevelopmental disorders, whereas the underlying etiologies are classified in the chapter on diseases of the nervous system or other sections as appropriate. So dementia is now not only a psychiatric morbidity as it should be. So we are always talking about behavior and psychological symptoms of dementia. Most of the people who are suffering from dementia, they were going to the neurologist, whereas the behavior and the psychological symptoms should be addressed by the psychiatrist. So I'm not saying this because I'm a psychiatrist. I'm saying it because of this was the consensus. And it should be like this. So we are responsible for the functioning and the emotional and the cognitive component of the dementia. So we should be treating it. But there was diversity. Now it has been there in neurology and psychiatry, both places. So it's no more a gray area. It's actually black and white here and black and white there as well. Clear cut guidelines how to go for it. Well, this is for today. I hope I made some sense out of it. Uh, Anybody, any question? No question? Anybody, any question? So either you have understood everything or you haven't understood anything. So I don't know what is the situation with you, or all of you are just in the
So
middle of.
let's go with the assumption that we have understood everything.
Okay, I'll go for this optimistic assumption that you have understood everything. As I mentioned earlier, and I have been mentioning it time to time, that I am also new to learn ICD-11 because it's just been 8 months since it was officially launched. Although I was reading ICD-11 for almost 2.5 years now, I was very much involved whenever there was something new coming in any scientific journal related to ICD-11. But WHO took lots of time actually to finalize this ICD-11. And as I said earlier, that this is an amazing set of classification system because now it is digitalized. And when something is digitalized and it's on the net, its acceptability enhances. That's the good part of it. I know that there are still few things that we have to understand, at least I have to understand. I don't know about you people, but I have to understand because there are some confusion about some diagnosis. But if you keep on using MMS, I'm 100% sure that you will be able to definitely understand it more clearly. And just to heads up you guys, appearing in IMM and FCPS Part 2, if your examiners are examiners, academicians, I am sure they will be more curious to ask the MCQs related to small nitty-gritty of the things that I have mentioned here. These were the major differences. So that was one thing that I felt I should cover. I should cover the understanding why ICD-11 is needed now. As I mentioned, it's new, it's latest, its reference can be used anywhere across the globe. Second, it has a very scientific, logical explanation of the things. Maybe we don't agree with some of them, like I mentioned to you about some of the things that were confusing for me, but it's good, it's effective, and it's reliable. So please make sure that you read it, understand it, and if you have any questions, we will definitely try to gather some data related to ICD-11 usage over next 6 months and present it in March, WPA Thematic Congress in Karachi, Pakistan. Thank you very much, all of you. If you have any questions, I am here. If no questions, then we can stop it, right? Should I stop the recording and then I expect questions from you? Okay, I have done that. Any questions?